Hi, it's Betsy Nicoletti. Thank you for joining me today. We're going to talk about three high-level facts about HCC coding. This isn't going to be in the weeds. I think it's going to be helpful, though, for clinicians, administrators, for new staff people, really just need a high-level view, particularly as we're thinking about the change from version 24 to 28. So diagnosis coding in a fee-for-service world, it establishes medical necessity and it gets the claim paid. We hope it gets the claim paid on the first submission. If we're part of an accountable care organization, shared savings, have risk sharing adjustments with our contracts, then diagnosis coding also communicates the complexity of the patient you're caring for, and it benchmarks the severity of the disease burden of the patients in your entire practice. So here are the three facts. Diagnosis coding measures and compares the disease burden from one practice to the next and uses that data to analyze cost and quality measures. So if you had two groups that had the exact same risk coding averages for their patients, but one had a lot of higher costs or lower quality data, the diagnosis coding is one of the factors in analyzing the outcomes. The updated risk model, version 24 to 28, version 28, doesn't change the work that practitioners do. And specific diagnosis coding really matters for chronic conditions, especially for those conditions that have a manifestation or a complication. So accountable care organizations, their activities, they're measuring the cost of caring for your group of patients. So what's the utilization? What are the resources that are being used? They're analyzing the quality metrics that for your patients, outcomes, hemoglobin A1C levels, getting preventive medicine services. And then they compare that utilization, the costs, and the quality measures with how sick your patients are. And, I've never met with a group of physicians, nurse practitioners, or physician's assistants who said, oh, our patients, they just aren't that sick. And how we communicate to the payer how sick this population of patients are and how that might explain the cost and quality metrics is on the diagnosis codes that get submitted on the claim form, and in some groups submitted within an extra file at the end of the year. Now I'm talking about chronic conditions. What about major events? There are some major conditions that are treated in the hospital, and these conditions are submitted on hospital claim forms. Prematurity, stroke, MI, trauma, end-stage renal disease, some kinds of cancers. So when a patient has been admitted to the hospital, I feel pretty confident that that condition is going to be submitted on a claim form by the facility. But if you have patients who don't go in the hospital, which we hope, we don't have all our patients go in the hospital every year, then the chronic conditions that are cared for in the medical practice make a huge difference in the risk score of your patients. So Medicare developed hierarchical condition categories, HCCs, and it's what Medicare uses in many other payers. It measures health by assigning scores to certain diagnosis codes. So not all of them, maybe about 10% of the diagnosis codes have a score. And that score, can be a high or low score depending on what Medicare believes will be the expected cost to care for that patient in the next year. Because HCCs were developed for Medicare Advantage plans, and it was a way for Medicare to predict for Medicare Advantage Organization A, how much will it cost for them to care for that patient next year? And that's where we got HCC scoring low these many years ago. So their HCC scores are calculated by age and gender, whether the beneficiary is living at home or in a nursing home in an institution, dually eligible, so Medicare only or Medicare Medicaid, which often indicates there can be higher costs, geography by county, and then the one I've underlined, diagnosis risk adjustment based on inpatient and outpatient claims, hospital claims, physician claims, and other professional claims, social worker, physical therapists. It doesn't use prescription drug data to say how sick the patient is, and it doesn't use diagnosis codes that are submitted on diagnostic tests like lab and imaging. So these diagnosis codes that are submitted on a claim in a calendar year, recalculated every year. If you have a patient who has a positive HIV status, you have to put that on the claim form every year, because by law, Medicare isn't allowed to look back 1 year ago, 2 years ago, 3 years ago, and pick up those diagnosis codes. They have to be submitted in this calendar year to be calculated for next year. It's by medical professionals on inpatient and outpatient claims. For each patient who has a diagnosis code that has a risk score assigned to it, those risk scores are added up based on being submitted on a claim in that year. If they were seen 5 times for the same condition, it's only counted once. And some diagnosis codes and conditions in the same category are counted once. So if you have a patient who has 2 types of complications from type 2 diabetes, that's in the same category, and it is only counted once. And then the model uses a hierarchy in calculating the score. So some conditions cause other conditions not to be counted, and it's an actuary's dream, that section of the rule. Specificity in chronic conditions is really important. So for some codes in some categories, the unspecified code either doesn't risk adjust or has a lower weight. Not every single one, but in some. So the 0.8 or 0.89 or the 0.9 code might not have a risk adjusted factor assigned to it at all, or it might be lower than one of the codes that's more specific. Codes with manifestations or complications tend to carry a higher risk code. So we don't want our clinicians, I have a book around here, it's about this thick, where it's all printed out. We don't want our clinicians to be looking in the book. They can see in some programs whether the code risks adjust or not, but they probably can't see the value. So what we really want you to think is, if your patient has a chronic condition and that condition is described by a manifestation or complication, use the specific code. Then there's one other piece about the hierarchy. So when certain conditions occur together, the risk score increases. It's like a boost. So if a patient has congestive heart failure and COPD, or COPD and chronic renal failure, this model predicts that the costs to care for that patient are going to be higher in the next calendar year. And so it gives the risk score a boost. These conditions don't need to be submitted by the same practitioner or on the same claim. So a patient who has chronic kidney disease and CHF, the same practitioner doesn't need to treat those both in the same day and submit them. They do need to be submitted in a calendar year on a claim form, or some groups will send a supplemental list. When they see, kind of where they're at, what services, what conditions haven't been reported. In the current year, CMS is using a blend of these 2 models, version 24 and version 28. In 2025, 1/3 of the score is based on the prior model and 2/3 is based on the new model. The guidelines for selecting diagnosis codes is the same. The purpose and function of risk coding is the same. So analysts, actuaries, accountants, compliance professionals, and administrators, they're calculating what this change will mean for risk scores. For practitioners, your diagnosis coding rules didn't change, your work doesn't change. And even in terms of being a coder, if you're abstracting codes from the claim, from the encounter, the fact that we're using version 24 versus version 28 doesn't matter. You're still going to code what's in the documentation. Now, ICD-10 says, code all documented conditions which coexist at the time of the visit that require or affect patient care or treatment. So code the conditions that you're treating, or this is the example that I always use. If you have a patient with diabetes, but their presenting problem is a terrible poison ivy, and the practitioner says, the last time this patient got prednisone, their blood sugar went way up. So because they have diabetes, I'm not prescribing the prednisone. So the diabetes affects the treatment today. We would add that to the claim form. Don't code conditions which no longer exist. That sounds so obvious, but the kind of conditions that get added to encounters that don't exist are really those based on ICD-10 rules. So if you have a patient who has gone into the hospital for a stroke, and now they come back and see the practitioner in the office, we're not coding a stroke that day. We code, if there's a residual, we code one of those I-69 codes where they have an after effect, a sequela of the stroke, or we code personal history of TIA or CVA. A patient who has a history of prostate cancer, we only code malignant neoplasm if there's still evidence of the disease or the patient is receiving treatment for it. So in that case, if they have a history of prostate cancer, but no evidence of the disease, not taking any hormonal treatment for it now, we would switch to personal history of malignant neoplasm, not malignant neoplasm. This is a long quote from a CMS document about risk coding. And they basically say there are some conditions, and these are the conditions that would have a risk adjustment score, that are managed with medications, and they have the potential for exacerbations if they're not treated properly. Excuse me. And it's likely that these diagnoses would be part of a general overview of the patient's health when treating coexisting conditions for all but the most minor of medical encounters. We also have the with guidelines in ICD-10. Now, this is a little less helpful in the office because our practitioners are essentially coding from the tabular. Our practitioners are not looking in the index and then going to the tabular listing. But if there's a condition that is linked with the word with in the tabular, in the index, then a coder can assume a causal relationship. So if you go to diabetes, then it says with, there's a whole list of conditions. If a practitioner had chosen diabetes unspecified and diabetes and cataract, say, then the coder could assume a causal relationship because in that index it has the word with. So we're going to add to the assessment and thus the claim form conditions that are evaluated and treated at the encounter, chronic conditions that affect the treatment of an acute problem. And how are we going to document that? Documenting a treatment plan, documenting the condition, the status of that condition, and a plan shows evidence of the assessment. So we're not coding conditions off the problem list. We're not assuming conditions based on medications that the patient is given. We can take information from a current HPI if it's there. But in general, the gold standard is we get to the assessment and the plan, and we see the condition, the status, and the plan. Those are the conditions that we're adding to the claim form. So our checklist for success for HCCs, see patients annually. Because remember, the payer isn't crediting conditions that were treated last year. They're crediting things that are reported in this calendar year. Some groups will begin to look in June and see which of their patients in their panel they haven't seen this year and begin to try to get them in for their annual exam or for a problem-oriented visit in that last half of the year. If you wait until November, it's too late. So see your patients annually. Report chronic conditions assessed and managed or conditions that affect treatment. There are few, but some status codes, and few, but some social determinants of health codes that risk adjust. But those, if it is either one of those, let's use homelessness, no access to clean water, not having transportation for medical appointments, things that are going to affect the outcome of your patients, you want to make sure you're coding those once in a calendar year. And select specific codes for chronic conditions that have manifestations, complications, or severity. So chronic kidney disease is defined by severity. We're going to want to use those codes. Thank you very much for listening. There is more information about HCC coding and other coding for medical practices on codingintel.com. Thanks very much.